Michaela Howells. I'm an assistant professor of anthropology at the University of North Carolina, Wilmington, and we're going to move from Seattle to going across the Pacific to talk about American Samoa. So specifically, I'll be looking at Zika virus and maternal stigmatization, supporting maternal and child health through religious engagement in American Samoa. The Pacific Islands are amongst the highest percentage of Christians on this planet per capita. Samoa itself is the #1 country in terms of percentage of Christians. Now, American Samoa, which I'll be talking about, would be in the top as well if it was separate from the United States. And I have this asterisk here because the top city, as you might imagine, is the Vatican, which is cheating just a little bit. Right? So we know that you have to know God through culture. If we're going to be asking questions about God as anthropologists, we need to understand it through culture. And as biological anthropologists, we are in a tremendous space to ask questions about the intersection of religious affiliation and health. Zika presents itself as a particularly important space in which to ask these questions. And that will become clear why specifically shortly here. So here in this talk, I'm sharing our research and asking about opportunities and barriers to care working through the church and with the church. I asked, does religious affiliation affect access to prevention with Zika? And do we see differences in maternal status, in marital status of those mothers and their access to care? For this talk, I'll be discussing non-charismatic and charismatic churches. I'll be discussing which churches fall into these categories. And this is a categorization that Samoans utilize to talk about differences within churches and the way that they interact with prayer and biomedicine. This project design is part of an ongoing 7-year project work that I've conducted in American Samoa. So there's 2 major components of this. One is an extensive chart review, which included all women giving birth within this period of time. Now, please note that this is a time period prior to Zika, the Zika outbreak. We have no indicators that the prenatal care access, which I'll be discussing, has changed since that point. These are women who are Samoan descent. They have no gestational diabetes. They're at least 25 weeks pregnant. And we looked at religious affiliation, marital status, and adequacy of prenatal care. In the last couple of years, we've gone back and conducted Zika questionnaires within the community and conducted additional ethnographic interviews regarding some of the material that we'll be talking about today. American Samoa is a United States territory, it's the southernmost United States territory. It's characterized by extended family networks and the integration of traditional chiefdoms and Christianity. At least 90% of the population is affiliated with Christian churches, and that final 2% is really in that unknown category or didn't answer or along those lines. In American Samoa, Christianity is embedded within the government, education, and healthcare systems. This is a non-secular system, although it's part of the United States. Commitment to churches is intense and active, both in terms of time and finances associated with it. And it's important to remember and recognize that missionaries and biomedicine arrived concurrently together. And with this, we see discussions of biomedicine being divine in origin. This is particularly important when we have outside health organizations coming in who look at and discuss religion as this barrier to care, especially when it comes to family planning, we'll discuss shortly here. And we see a lot of discussion associated with religious ideals associated with care. So Jessica Hardin's work, who's one of my co-authors in this work, spends a lot of time discussing these sorts of relationships. So churches in American Samoa, if we're taking this broad sweeping in terms of comparison, have similar views on family planning and premarital sex. So that your family planning is really reserved more for people who are married, although unmarried women can gain access to it. But premarital sex is seen as something that should be avoided and that women should be making, I'd say, like good decisions to avoid. But they have different perceptions amongst churches of the role of biomedicine and prayer and healing. So more specifically, when we're talking about the non-charismatic and charismatic churches will have more emphasis on trusting God to take care of the pregnancy, right? The more that you pray, the better health you'll be in and the better position your pregnancy will be in. And much of this component of my research is based off my ethnographic work, where women would indicate that they waited to get prenatal care, in part because they were worried that these are members of charismatic churches, that worried that if their pastor found out that they were coming in for prenatal care and accessing care, that they would think of them as not being true believers, right? Because they weren't allowing Jesus to take care of their offspring. So we looked at this data and tried to understand, okay, do we see a difference in terms of access to care with Zika, which I'll discuss in just a moment here? Do we see less reliance on biomedicine? So in terms of breaking down the churches, this gives you an idea. There are other churches that we added in our analysis. Just to give you an idea. And this, again, non-charismatic, charismatic is a way that Samoans talk about it. They also talk about old churches, which are non-charismatic, and new churches, which are the charismatic, or evangelical, non-evangelical, or non-evangelical, evangelical, rather. Okay, so churches play an incredibly important role in terms of health, not just in American Samoa, but in many spaces. But in American Samoa specifically, we see that they are a gathering place for people to come together to discuss ideas. Much of education is occurring within the church community. In a study that was done in 2011, all church leaders that were asked this question, the Department of Health should work with the church for disease prevention. 100% of those church leaders agreed with that. And then we had great successes working with the Department of Health and the church communities to work with filariasis campaigns, influenza, diabetes, dental, and eye exams. So this is teeny, teeny, tiny, even though it's a giant screen, but this is brought to you by the Seventh-day Adventist Church, right? So bringing in this additional support to an incredibly resource-stressed health environment. So major, major avenues. However, there are also some challenges associated with this. So in this image on the left, this is from the Coalition for Teen Pregnancy Prevention in American Samoa, which is a coalition that's made up of doctors, nurses, healthcare professionals, community leaders, including church leaders. And the take-home of this is that we'd have no unintended pregnancies on island if we can align our church, our Christian way of life, our family and family unit, and the cultural unit and the rules associated with it. If those are all in place, we'd have no unintended pregnancies. So if there is an unintended pregnancy, especially these premarital pregnancies, it's because someone in one of these categories is problematic and needs to be readjusted. I include the Samoa News piece. So Samoa News is the #1 news source on the island, or in the islands, American Samoa. So Samoan Catholic Church gives thumbs down to free condom plan, right? So they wanted to give out free condoms, put them out in the university setting, and this was seen as inappropriate by the Catholic Church, and they pushed very, very hard against this. And we have a comment below, and this is from a Samoan, actually no, the person who made the comment blocked her name out here, but she said, and I will read it in my voice instead of hers. No, you don't want them to get abortions and have safe sex, but you condemn and look down on those who are teen parents and have children out of wedlock. What would Jesus do? Okay, so we recognize that there's this stigma associated with premarital sex and also around components of family planning, especially condoms. There's no sex education in schools, and this is a direct tie into religious pressures, with the idea that if children learn about sex, if they learn about condoms, that they will be more likely to be in these kinds of behaviors. So this leads to the challenges, specifically with Zika prevention. And I'm going to speak today specifically about prenatal care, which is your main form of getting Zika education if you're in American Samoa, and condoms, which is one of the ways to prevent Zika transmission. So when we think about Zika, most people are familiar with these just heartbreaking pictures of these microcephalic babies. But we also know that across the globe is not the same in terms of microcephaly. But what we do have is a tremendous number of issues facing these neonates as they grow into childhood. And specifically in American Samoa, we're seeing increased rates of hearing and vision deficits, and also higher rates in miscarriage and stillbirths. And this leads to substantial physical, emotional, and financial burdens on mothers that we discuss elsewhere, that we're presenting elsewhere. Okay, so in terms of the risk factors associated with Zika, mosquitoes is one that is, people typically see on health posters. If you think of traveling through the airport, you may have seen a Zika poster that's all about mosquitoes. Keep that in mind. Intrauterine transmission, so between the mother and her fetus, and sexual transmission. There is no treatment for Zika. There's only prevention as an option. So education, how to prevent, being able to follow, how to prevent and how to follow through with that prevention. We're discussing that for the record at 4:45 in false meritocracy of choice in that section if you guys would like to join us. The CDC recognizes that the highest risk factor is for the fetus in that first trimester. So with this, we pinpoint the time in early prenatal care as the most critical point to be able to get education information to mothers. So the first prenatal care appointment, you get your prevention education, and also you get your Zika kit. So for instance, this is your Zika kit, so you get a bed net, you get 6 larvicidal dunks, you get 2 cans of 6 ounces of off, which if anyone spent any time in the Pacific, you'll know that lasts maybe a week and a half per can, and you're living with a household of 12 to 20 people, so you're sharing it. 2 outfits worth of permethrin. Again, Samoan women, they change frequently, they have matching outfits for all different events, right? 2 are not enough. And speaking of not enough, you get 7 condoms for the entire length of your pregnancy. My previous research shows that married women across the board receive earlier and more prenatal care. And so with this, you can identify this as an issue in terms of who is getting care and who has access to these prevention methods early on. So I ask here, does religious affiliation affect the timing of care, like the timing of prenatal care? Do we see differences within these religious affiliations? And do different outcomes, are there different outcomes in terms of religious affiliation associated with marital status specifically? So we did not find a difference in terms of prenatal care visits, the number of prenatal care visits, thank you, the number of prenatal care visits, or the gestational age in which women sought out their first prenatal care. And combined, this is the adequacy of prenatal care unit that uses these measures together, we did not find a relationship here. But what I want to draw your attention to are these extraordinarily extraordinarily high rates of inadequate prenatal care that we face on this island and that we're addressing. And so there's an issue that we're looking at in terms of, okay, what is driving these low rates and how can we improve this? We also found no differences in marital status, which I was very surprised by because of how people talk about it, like, oh, if you're part of this group, then you're even higher, like a higher shame level, if you will, for being unmarried and pregnant. We didn't find that. Okay. In terms of condom stigmatization, we asked a simple question. Should women, true or false, women in American Samoa should wait to get pregnant until the risk of Zika passes? 61% of men agreed with this, and only 31% of women did. The issue that we'd like to bring up here are potential religious barriers to prevention associated with condoms, right? So we know that condoms are associated with pregnancy prevention and STIs, and so these can be tied in or talked about as indicative of sin. They're expensive both financially and socially. And they're concerned that the youth will have sex if they have access to condoms. So what we see is that condoms and prevention of sexual transmission is missing from public Zika education. We don't see these posters. And again, as you're going through TSA, look for your Zika posters because they very rarely ever include sexual transmission. It's all about don't get around mosquitoes. Okay, so we see no difference between a religious affiliation and with this means that the understanding of roles of prayer and biomedicine do not seem to be impacting access to care. So those groups, which the charismatic groups that put a greater emphasis on prayer over biomedicine, does not seem to be affecting the rates in which women are accessing care, which is great. Okay, so how can we improve this relationship in terms of biomedicine between the church and specifically around Zika? Well, culturally sensitive care, which is inclusive of churches and including them in this dialogue, right? So what we see is a lot of off-island organizations, large-scale medical organizations coming in and trying to work around the churches instead of with the churches. And the church is Samoa. Building on cultural value of the pregnancy and the child, avoiding top-down approaches from the outside, people coming in and telling them how to reach their communities, and working with that church infrastructure for education outreach. They also, in an especially excellent place to aid in determining socially appropriate locations for condom distribution. So opposed to going in, so we had 5,000 condoms, which, by the way, 5,000 condoms is like a crate this tall to the floor. Condoms, instead of coming in and sort of passing them out, right, working with them and say, okay, where can we put these so that we can help improve the health of our mothers, right? So these women using condoms during their pregnancies to prevent it. Where can we put these? How can we get these out? And they want to talk about that. They work together, so together instead of against. And this also opens a really important door in terms of working with churches in terms of condoms and making condoms less stigmatized. Because here's a space you can get this disease through mosquitoes and transmit it to your wife through sexual transmission. So this is a space we might be able to improve access to condom access. Thank you very much.